All right, welcome back to PodBites. So in our last episode, we talked about the infant of a diabetic mother, and today we dive into a topic that every station loves, neonatal jaundice. If you're doing OSCEs or NICU rotations, you'll see this 10 times a day. And the trick isn't what is jaundice, it's why it's happening. So let's start simple. Why do newborns get jaundice so easily?
So, bilirubin production starts when red blood cells break down into heme. That heme is converted by enzymes like heme oxygenase and biliverdin reductase into bilirubin. Then, another enzyme, uridine glucuronal transferase, conjugates bilirubin in the liver, making it water soluble for excretion.
So the liver basically has to package bilirubin so the body can get rid of it. Which makes me wonder, newborn liver, is it actually good at this?
Not really. That enzyme system is immature, so unconjugated bilirubin builds up more easily, which is why physiological jaundice happens so commonly.
Okay, I'm gonna say 3 terms people mix up: physiologic jaundice, breastfeeding jaundice, and breast milk jaundice. Help me separate them.
Physiological jaundice is the normal one. It starts around day 2 to 4 and resolves before week 2. It peaks under 15 milligrams per deciliter.
So if I see jaundice on day 1, alarm should go off?
Yes, jaundice in the first 24 hours is almost always pathological. Breastfeeding jaundice happens early, usually in the first week, because of inadequate intake. The baby isn't getting enough calories or fluids, so bilirubin isn't cleared properly and it builds up. But breast milk jaundice happens later, from about day 5 onward, because substances in human milk increase enterohepatic circulation. It can persist for weeks because bilirubin keeps getting reabsorbed.
So physiologic equals normal, breastfeeding jaundice equals not enough intake, breast milk jaundice equals milk composition itself. That's actually super clear. Alright, we said day 1 jaundice is pathological. What else puts it in the nope, this is not normal category?
If the bilirubin is conjugated, conjugated jaundice is never physiologic. It always points to liver, biliary, infectious, or metabolic problems.
So unconjugated can be normal or not, and conjugated is always a red flag. Okay. Walk me through this part slowly, because whenever I see bilirubin numbers, my brain freezes. How do I actually look at the labs and decide what kind of jaundice this is?
Think of it like splitting the bilirubin pie. If a slice is big, more than about 20%, is conjugated, then that's direct hyperbilirubinemia.
So if most of the pie is unconjugated, we're dealing with indirect?
Exactly. Less than 20% conjugated equals predominantly indirect.
Okay. Suppose it's unconjugated. Now what?
Then we follow a hemolysis pathway, starting with a Coombs test. If Coombs is positive, that suggests immune-mediated hemolysis, classically Rh disease or ABO incompatibility.
Hold on, can we pause on Rh disease for 1 second? I feel like we hear about it constantly, but I want to understand what's actually going on.
So, picture this. The mom is Rh negative, the baby is Rh positive, and the mom's immune system sees those Rh antigens as foreign. She makes IgG antibodies, or anti-D antigen antibodies. Those antibodies can cross the placenta and start destroying the baby's red blood cells.
Right, and this gets worse in later pregnancies because her immune system remembers this, right?
Exactly. The first pregnancy is kind of the sensitization, and after that, the response is stronger and faster.
And our prevention strategy is basically to stop her from ever making those antibodies in the first place, using ROGAM.
Yes, given around 28 weeks and again closer to delivery. It blocks the whole cascade.
Okay, that makes a lot more sense. Now, what if Coombs was actually negative?
Then we check hemoglobin. If hemoglobin is high, we think increased red cell mass, like twin-to-twin transfusion, maternal-infant transfusion, or delayed cord clamping. If hemoglobin is normal, we look at reticulocytes. If reticulocytes are high, non-immune hemolysis, such as spherocytosis, G6PD deficiency, or pyruvate kinase deficiency. If reticulocytes are not elevated, it's not hemolysis. We think reabsorption, for example, hematoma, or increased enterohepatic circulation, such as breastfeeding jaundice or breast milk jaundice.
So all the hemolytic causes get sorted naturally by that step-by-step algorithm.
Exactly. And the non-hemolytic unconjugated cases, things like polycythemia or hypothyroidism, appear when there's more bilirubin production or delayed clearance even without hemolysis.
Alright, now what if it's direct bilirubin?
Direct bilirubin is always pathological. So now we're thinking hepatobiliary disease or obstruction. That includes congenital infections like TORCH, metabolic issues like galactosemia or alpha-1 antitrypsin deficiency, and obstructive diseases like biliary atresia or choledochal cyst. So, we investigate with a HIDA scan, liver ultrasound, and a sepsis or metabolic evaluation.
So the direct side is basically something's wrong with the liver or bile ducts, and the indirect side is are we destroying red cells, making too many, or not clearing them?
Exactly. And once we sort those branches, management becomes much clearer.
All right, let's talk about treatment because the minute someone says jaundice, everyone jumps to phototherapy. What do we actually do?
We rely on a very specific nomogram, a chart that plots the baby's bilirubin levels against age in hours. We don't just pick numbers randomly, we follow that chart to know whether phototherapy is needed or not.
Right, the famous chart that everyone Googles during call.
Exactly. And to give you a sense of the numbers, if a term baby has a total bilirubin that's above the 95th percentile for their age in hours, that's when phototherapy becomes appropriate. The light changes unconjugated bilirubin into a water soluble form, so the baby can clear it without needing to conjugate it. It's a chemical shapeshift that lets the body excrete bilirubin more easily. And if the bilirubin keeps climbing or isn't responding fast enough, that's when we escalate to exchange transfusion.
And phototherapy isn't totally harmless either, right?
Exactly. You can see temperature instability, rashes, and if the bilirubin is conjugated, there's a risk of something called bronze baby syndrome, which is why phototherapy is basically useless and actually not recommended for direct jaundice.
So, if phototherapy doesn't really help conjugated jaundice, what do we actually do?
With direct hyperbilirubinemia, the focus shifts to figuring out the cause. We're thinking liver disease, biliary obstruction, metabolic issues. So management becomes about treating the underlying condition rather than just trying to lower the bilirubin number. It's a detective situation, not a shine a light and fix it situation.
So, indirect jaundice is about clearing bilirubin, direct jaundice is about finding the root problem. And either way, there's a reason we're being so aggressive here.
Right, because the whole reason we monitor bilirubin so closely is to prevent kernicterus. That's when unconjugated bilirubin crosses into the brain and deposits in areas like the brainstem and the basal ganglia. Early on, you might see poor feeding or hypotonia. Then you can see hypertonia, or a high-pitched cry, or a bulging fontanelle. And later, you're dealing with developmental delays, hearing loss, and extrapyramidal symptoms.
So, everything we do phototherapy, bilirubin checks, escalation it's all to stop bilirubin from ever reaching the brain in the first place. Because once kernicterus happens, we can't actually reverse that damage. Before we finish episode 5, just 2 things to think about while we recap. Why is jaundice in the first 24 hours such a red flag? And what happens to the Coombs test and Rh incompatibility, positive or negative? Keep those in mind while we run through everything we covered. So today we said jaundice is common in newborns partly because the liver enzymes that conjugate bilirubin are still immature, so unconjugated bilirubin builds up easily.
That's what gives us physiologic jaundice, appearing around day 2 to 4 and resolving by week 2. But jaundice within the first 24 hours is almost always pathologic, so that timing matters.
Then we separated the 2 breastfeeding terms people mix up. Breastfeeding jaundice, early from inadequate intake, versus breast milk jaundice, later because milk components increase intrahepatic circulation.
After that, we move to the actual evaluation. If bilirubin is unconjugated, we start a hemolysis pathway, beginning with a Coombs test. A positive Coombs test points towards immune hemolysis like Rh or ABO incompatibility. A negative Coombs test pushes us towards other causes like G6PD deficiency or polycythemia.
And if bilirubin is conjugated, there's always pathologic. We start thinking hepatobiliary disease, biliary atresia, metabolic disorders, torch infections. And that's when imaging like HIDA or liver ultrasound enter the picture.
Management depends on the bilirubin nomogram, using phototherapy when the level crosses the threshold, and escalating to exchange transfusion when bilirubin is dangerously high or doesn't respond. And remember, phototherapy only works for indirect bilirubin.
And all of this monitoring exists for one reason: preventing kernicterus, where unconjugated bilirubin crosses into the brain and causes permanent neurologic injury. Once it happens, we can't reverse it.
So, jaundice in the first 24 hours is a red flag because it's pathologic.
And Rh incompatibility gives us a positive Coombs test.
And that wraps up episode 5.
Thank you for tuning into PodBites. Keep learning, and we'll see you next time.